So this is our presentation on our Bevan Exemplars project, integrating self-management interventions into pain pathways. And the project team consisted of my colleague.
Hi, my name is Grevin Jones. I'm one of the clinical specialist physiotherapists within the pain management service in the East Service in Betty Cadwallader.
Hi, I'm Ruth Burgess. I'm one of the clinical nurse specialists in the Wrexham Pain Management Service.
And I'm Dr. Katy Knott, and I'm a consultant clinical psychologist in the East Pain Management Service.
So first off, we will start with an overview of our project, which was to look at available self-management resources and to collate these for use with patients referred to our service. We identified that individuals accessing our service have often received little guidance, support or practical measures prior to their referral. The pain service in Wrexham currently has lengthy waiting times for assessment and intervention. So we felt that we needed to be able to offer and signpost people to guidance at an earlier stage. Evidence does suggest that longer waiting times can lead to a worsening in well-being, mood and physical presentation, and this can also lead to an increased reliance on medications. We therefore identified that improving access to self-management resources during the waiting time was fundamental. Our Bevan project did alter from its initial idea due to the lack of available resources to access, but also due to the short time framework of the fast track programme. The pilot project we will be discussing evolved during scoping and discussions with Helen Housen. We decided to undertake a pilot project integrating the education programme for patients chronic pain course into our secondary care pain service pathway. So moving on to a summary of our aims, we wanted to increase the accessibility of high quality self-management resources for those people experiencing persistent pain. We wanted to reduce the likelihood of pain becoming further established in its chronicity or health and well-being further deteriorating by providing access to self-management resources whilst an individual is waiting to be seen by a specialist pain service. We wanted to improve patient outcome and experience, reduce service demand due to decreased need for direct clinical contact, and reducing demand for face-to-face contact with clinicians was of particular importance during the current pandemic. We wanted to move towards a stepped model of care with individuals who were more engaged in a self-management approach, being able to work through resources independently at an earlier stage in their care. This would lead to those with more complex needs being seen in a more timely manner in lines with principles of prudent healthcare. We wanted to embrace new ways of working by providing access to a remote self-management programme, improve coordination between services and therefore reduce duplication of work, and identify barriers to engagement with self-management resources.
So this diagram provides you with an overview of the pilot project. So if you start on the left-hand side of the diagram, 100 patients were offered the Education for Patients programme, and they were contacted by telephone to offer this intervention to them. And these were patients already on the waiting list to see the pain management service in the East in Betty Cadwallader. Of those 100 patients, 71 agreed to a referral to the Education for Patients programme. And of those, 57 opted in once they were contacted by the Education for Patients programme administrative staff. So just to provide you with a brief overview, the Education for Patients programme, or EPP for short, is a 6 weeks intervention with one additional week to orientate participants to accessing a remote intervention. So it is run over 6 weeks, 2.5-hour sessions, and anybody who completes 4 out of the 6 sessions are considered to have completed the course. So for our course, which was a specific EPP aimed at helping people to live alongside their pain, 32 attended the first session, and then 21 of those completed. So completed 4 out of the 6 sessions. Psychometrics were completed pre, so our first point of contact, and post-intervention as well. But we also completed our own psychometrics when those patients were referred to our service too. And just to let you know that there has been intervention similar to this run before in Australia, in Perth, and over there they found about a 50% uptake of self-management interventions, which is similar to our opt-in of 57 out of the 100. So just to provide you with an overview of the key outcomes. So of the 100 individuals offered EPP, 32% attended the first session, which isn't a bad uptake really. 66% of those who attended the first session completed the whole course, which in terms of attrition rate isn't bad at all. And 77% of those who attended EPP reported that they found it to be beneficial. And actually, at least one of those individuals went on to say that they didn't need our service afterwards, and others have said that they needed kind of less input from our service, or we felt that they did. So in terms of the standardised outcome measures, those evaluating patient outcomes, we mainly kind of focused on measures around mood and patient experience at point of referral to our service, pre-EPP and post-completion of EPP, and they all demonstrated an improvement across all domains, with mood demonstrating a significant improvement post-intervention. Of those who didn't engage in EPP, so the people who opted out, 96% cited lifestyle reasons. So actually there was a lot of stuff around work-related issues, COVID-related issues, caring, etc. And only 4% stated that they didn't believe the programme would be relevant. So actually most of the patients who were contacted felt that it would help them in some way. Longer term outcomes. So our hope is that integrating EPP into the referral pathway might reduce demand on services, because individuals will be accessing advice and support to self-manage their condition at an earlier point in their pain journey. We're hoping that waiting lists and waiting times might reduce as a result, and we would therefore be able to focus on those who have the greatest need in line with principles of prudent healthcare. We hope that by integrating EPP, it would result in better engagement with the pain service, because patients would be orientated to a self-management approach at an early point in their pain journey, which is the basis of our service really. And it would reduce resource demand, because essentially what we're hoping is if we offer EPP early on in a patient journey, they would then go on to need less clinical contact hours under our service.
If we look at the patient experience, so look at the feedback that we had. This is a little bit of a flavour of what was returned. On the whole, this was all positive. It tended to give themes around patients having some kind of solutions, developing skills through that time, having a structure to work through, and also giving a focus. I think one of the comments there says that there was nothing I didn't know already. And that might allude to that we still have some work to do about patient selection, but on the whole, it seemed to reflect that patients at access to our service really got benefit from having this guidance at this juncture. Okay, so scaling up now from what we've already found from our study is that we have around about 738 patients waiting for our service already. So to deal with that backlog, potentially 12 EPPs could deal with 236 patients of that total. If we look at that now across North Wales, we've got a backlog at this current moment in time of just shy of 2,000 patients. Providing 31 EPPs could then address the backlog of patients and address a total of 623 patients. Moving forward, if we're able to provide this for patients at the point of referral, then in our own service we receive about 1,000 referrals a year. With a 32% uptake, that would mean that 16 EPPs, or about 1.5 a month, so 3 over a 2-month period, would be able to deal with 320 patients at the point of contact. And our future direction for this now, well, I suppose we would like to now use this information and maybe provide a larger scale project, really. This could be multi-site. So if we think about Betty Cadwallader, we have 3 pain centres. So we could maybe see if we could use this over the 3 centres to get more information. We might be able to then progress this further to identify the predictors of engagement. So by evaluating the outcomes, which patients would potentially get a better outcome from utilising this service. As we move through the pathway, we want to be able to evaluate how EPP impacts on that individual person. Would that mean that that individual person would require less input from our service? Maybe not even need any input from our service? Or would their expectations be addressed so that it would improve patient satisfaction? It definitely was an aspect of the service which we wanted to improve, and that was around how we offered this service. We provided this project during the second wave of COVID, and because of that, I think there were certain aspects which we could have improved, and it's certainly about how we provided the offer and what information we provided alongside it to inform patient choice. We certainly want to continue integrating with other services. We know that the burden of pain is large, and that small services will never be able to provide what patient need is. So integrating with other services provided would significantly improve our patient contact. And lastly, we want to work alongside other pain services. Potentially this could be a service which we could adopt and spread across the whole of North Wales, as well as the whole of Wales. Thank you.